Our first speaker is an epidemiologist and has authored and presented several research papers locally and internationally. Friends, to talk on antibiotic stewardship and the pediatrician, let us all welcome Dr. Rosemarie Arciaga.
Good morning, everyone. Actually, the topic given to me, antimicrobial stewardship and the pediatrician, is quite a challenge because, this topic traverses all specialties, multiple specialties, not just pediatrics. And also, this may not sound as interesting as treatment of a specific infectious disease, but it is important for us to understand what this is all about because this will impact on all of us once the Department of Health implements antimicrobial stewardship program in all hospitals in the Philippines, private and public hospitals. So, based on the objectives given to me, I have prepared this 5-point outline. Rationale for antimicrobial stewardship, clinical approaches, guideline recommendations, research gaps, and future plans. Antimicrobial use has undoubtedly reduced mortalities caused by infections, but its inappropriate use has increased the rates of serious diseases caused by multi-drug resistant organisms. MDROs, as we know, is associated with poor clinical outcomes, increased lengths of hospital stay, and increased healthcare costs. Pediatric practice, which is our field, the field where we revolve, is one where antibiotic is often used, yet misused. Tama ba? Hindi, quiet lang sila. Okay. Inappropriate use of antibiotics in pediatrics occurs in the following situations. Use of antibacterials for diseases not caused by bacteria. Treatment of culture results that reflect just colonization or contamination rather than true infection. Use of broad-spectrum antibiotics where narrow-spectrum agents are equally effective, and prescription of antibiotics longer than necessary or at inappropriate doses. Let us look at the 30% rule in antimicrobial prescribing. Approximately 30% of all hospitalized patients receive antibiotics. Over 30% of these are prescribed inappropriately. Approximately 30% of hospital pharmacy costs are from antibiotics. Fortunately, 10 to 30% of these costs can be saved by an effective antimicrobial stewardship. So what exactly is antimicrobial stewardship? It is a coordinated intervention designed to improve antibiotic use by promoting the selection of optimal drug regimen. Antimicrobial stewardship is a systematic approach to the use of antimicrobial agents in order to achieve optimal outcomes. These are improved patient outcomes like cure, less toxicity, and reduced adverse events, or improved community outcomes like decrease in antimicrobial resistance or reduced healthcare costs. Despite of these benefits of antimicrobial stewardship, it's quite ironic that very few hospitals here in our country have implemented a comprehensive antimicrobial stewardship program, which, by the way, will be required by the Department of Health to be implemented in all hospitals in the Philippines very soon. With that said, it becomes important that we acquaint ourselves with the clinical approaches to antimicrobial stewardship. There are two major approaches to antimicrobial stewardship: front-end approach and back-end approach. Front-end approach is exemplified by pre-authorization and formulary restriction. In here, certain antimicrobials are considered restricted and would require prior authorization before you can prescribe them. In this approach, clinicians must contact the antimicrobial steward and obtain approval prior to prescription. The other one is back-end approach. This is exemplified by prospective audit and feedback. In this approach, we are free to prescribe whatever we want, even if they are monitored antimicrobials. However, after 2 to 3 days, the AMS team will come in and they will review the antibiotic that we have ordered and provides us with recommendations to either continue, adjust, change, or discontinue the therapy based on culture results and clinical features of the case. On top of these two approaches, there are 8 other clinical approaches to AMS. First, education. This is essential but insufficient alone. Clinical guidelines or clinical pathways. This can decrease the amount of critical thinking when made available in the point of care. You don't need to think anymore, just copy. The escalation or streamlining. This is when you modify initial empiric therapy to targeted, very specific therapy based on culture results, or you discontinue redundant concurrent antimicrobials with overlapping coverage, or totally stop the antibiotics in the absence of infection. That's the escalation or streamlining. IV to oral switch. This is for antimicrobials with excellent oral bioavailability, wherein timely conversion to oral can be done. Examples of drugs with excellent oral bioavailability are the chloramphenicals, clindamycin, metronidazole, macrolides, azithromycin, and erythromycin, the fluoroquinolones, linezolid, and among the antifungals, fluconazole. Dose optimization. The dose of antimicrobials can be optimized for better microbial kill based on patient characteristics and the drug's PK/PD, among others. And how do we enhance microbial kill based on PK/PD? For instance, prolonged infusion of beta-lactams, increased frequency dosing of the quinolones, and OD dosing of aminoglycosides. What about computer-assisted decision support? This is an electronic system that will guide clinicians regarding appropriate dosages and administration of the drug. Written or electronic order sets and treatment algorithms. They will ensure guideline-based appropriate empiric antibiotic choices. And last, we're also familiar with this, antibiotic cycling. This is the scheduled removal or substitution of specific antimicrobials. And the hypothesis is that by removing specific classes of antimicrobials on a regular basis, the development of resistance may be avoided. These approaches, either singly or in combination, can be adopted in your hospital within the program called AMS, or Antimicrobial Stewardship. But how do we start? First, to come up with an AMS program in the hospital, it would be good to get baseline evaluation of the current practices, the antibiotic use, and the pattern of use. Then establish a multidisciplinary core team. The team is responsible for developing, implementing, and managing the program. It would be helpful if you identify a group of prescribing pediatricians that can serve as program champions, or what we call model prescribers. Maybe some of you can be model prescribers. This is important. Why? Because obtaining physician buy-in is crucial to AMS success and sustainability. Plan the implementation. What is the specific ID syndrome and the specific pathogen that will be targeted? What drugs will be classified as monitored or restricted? And strategize the rollout. What specific strategy or clinical approaches or combination of approaches you want to adopt. And throughout the implementation, evaluate. You have to evaluate the clinical, microbiologic, and economic outcomes. And you present these data to the leadership so that you'll get the support that you would need. Now, let us see what the guidelines tell or say about the AMS programs and the clinical approaches. To date, there are 3 guidelines for antimicrobial stewardship that have already been published. The 2006 guideline was developed by experts in infection control, and it stresses the causal relationship between antibiotic use and resistance patterns. In this guideline, recommended are the following. We have to stop and fund prevention programs, track infection rates, and use standard infection control practices. A year later, in 2007, the Infectious Disease Society of America came up with its own set of guidelines for the development of programs to enhance antimicrobial stewardship. This document actually embodies the 4 elements of a successful stewardship program. There must be a multidisciplinary team. The program must be comprehensive. There should be collaboration between the ICC, the pharmacy, and the therapeutics committee, and there must be support from hospital administration. Recommended in this guideline are 2 core strategies. Core strategies that lead to reductions in inappropriate antimicrobial use and costs. These are pre-authorization and formulary restriction, as well as prospective audit with intervention and feedback. In pre-authorization, as I have mentioned earlier, clinicians need to get approval to use restricted antibiotics before they are prescribed. And restricted drugs are last-line antibiotics that demand preserving their use to conditions where they are truly indicated. Prospective audit, on the other hand, is when antibiotic stewards engage the prescriber after antibiotic has already been prescribed, typically after 2 to 3 days, to optimize antibiotic treatment. Examples of prospective audit strategies: one-on-one patient-specific education to be conducted by an ID specialist regarding disease epidemiology, local antibiograms, and clinical literature. Not on all cases, but only when the pharmacy receives an order for a restricted drug. Or there can be suggestions from an ID specialist or a clinical pharmacist regarding the more appropriate agent and its administration. In areas with limited resources, a scaled-down model may be adopted, that is, using an ID physician or a pharmacist with ID training, just 3 days per week, to review only those patients receiving multiple, prolonged, or high-cost courses of antimicrobial therapy. If there are core approaches, there are what we call supplemental strategies. And recommended in this guideline are 5 out of the 8 supplemental strategies. And these are education, guidelines and clinical pathways, streamlining and de-escalation, dose optimization, IV to oral conversion. Just these 5. Almost 10 years after the first IDSA guideline, IDSA updated its guideline, released last year, with a statement on leadership. It says that AMS programs should be led by physicians and pharmacists, including ID specialists. Recommended are 3 programs shown to improve patient outcomes, reduce antibiotic resistance, and save money. And again, these are pre-authorization and prospective audit, syndrome-specific intervention, and rapid diagnostic testing. The guideline states that pre-authorization of broad-spectrum restricted antibiotics and prospective review or audit should form the cornerstone of antibiotic stewardship programs to ensure that the right drug is prescribed at the right time for the right diagnosis. Hospitals are advised to choose one or both of these methods based on local resources and expertise. Syndrome-specific interventions. The guideline recommends focused and multifaceted interventions for the treatment of very specific syndromes, say pneumonia, UTI, or healthcare-associated infections only, rather than trying to improve treatment of all infections at the same time. This method makes stewardship more manageable, more practical. It provides a targeted and clear treatment message rather than trying to disseminate 100 different lessons at the same time. Rapid diagnostic testing. This can help determine if the cause is viral and therefore would reduce the inappropriate use of antibiotics. Rapid testing of blood cultures, for instance, in addition to conventional culture, may be helpful, leading to quick results and therefore early de-escalation. What are the other recommendations? We have to reduce the use of antibiotics associated with Clostridium difficile infection. We have to reduce our use of cephalosporins, of fluoroquinolones, of clindamycin, and extended spectrum penicillins, because these are all associated with Clostridium difficile infection. We have to implement antibiotic timeouts to encourage us prescribers to perform routine reviews of our respective regimens and use computerized decision support whenever possible. What are not recommended? Relying solely on educational material is not recommended because any improvement will never be sustained. Lectures and brochures should only be used to supplement the core strategies. And about antimicrobial cycling, so far there's insufficient data to advocate its use. Therefore, at this very minute, it is not recommended. Moving on to research. There are thousands of researches on antimicrobial stewardship, but for the purpose of this talk, I limited my search to systematic reviews which aimed to answer these questions. What is the effectiveness of AMS programs on primary outcomes and secondary outcomes as listed? And what are the barriers to implementation and sustainability? First, what is the effectiveness of AMS program on clinical outcome, say mortality? In this meta-analysis consisting of 34 clinical trials, the authors computed a total odds ratio of 0.65 with a 95% confidence interval of 0.54 to 0.8. They looked at the effectiveness of CPG-based empiric antimicrobial prescription on mortality, and the study concluded that prescribing according to guidelines was significantly associated with reduced mortality with a relative risk reduction of 35%. What about another clinical outcome? Length of hospital stay. In this meta-analysis of just 4 clinical trials, overall effect size was found to be negative 0.09. There was indeed a 9% decrease in length of hospital stay in favor of AMS. Now this is interesting. What is the effect of antimicrobial programs on antimicrobial prescribing? And this slide shows us the mean improvement in antimicrobial prescribing across different types of clinical trials, RCT, cluster RCT, controlled before and after, intermittent time series, etc. And comparing persuasive and restrictive methods of intervention. Persuasive methods advise physicians how to prescribe. Restrictive methods put a limit on how physicians prescribe. And this study shows that whatever intervention type, whether it's persuasive or restrictive, this brought about improvement in antimicrobial prescribing. So it can be said that persuasive and restrictive methods of intervention to improve antibiotic prescribing have both been successful. Now let's take a look at the more recent, this is still hot, more recent systematic review from the Cochrane database, published or released just last week. The authors looked into the interventions to improve antibiotic prescribing practices for hospital inpatients. They computed a risk difference total of 0.19 with 95% CI of 0.15 to 0.23. And they concluded that interventions were effective in improving antibiotic prescribing, defined as increased compliance with antibiotic policy and reduced duration of antibiotic treatment. In the same article, they did meta-regression. And in meta-regression, whenever you have a value of beta of above 0, that means that's favoring the intervention. And this figure shows that enablement increased the effect of interventions, including those with restrictive component. What is it? Simply said, those interventions that provide advice or feedback, that's enablement, and restriction to physicians were effective in improving prescribing practices compared to those that did not. What about cost? AMS programs led to a 34% decrease in antimicrobial cost, according to the systematic review by Karanika et al. Second question, what are the barriers to implementation and sustainability of inpatient AMS? Whether you're in America, in Europe, in Asia, or Africa, the main barrier to program implementation is lack of funding, lack of people. And in Asia, on top of lack of funding, there is lack of information technology. At this point, I would like to call your attention to the purple bar, that is prescriber opposition, seen in 11 to 16%, which brings us to an article which is very relevant to us in pediatrics, entitled AMS in Pediatrics, Focusing on the Challenges Clinicians Face. In this study, they stratified their participants into staff pediatricians, those are the consultants, and the pediatric residents. And take note that discontinuing antimicrobials if there is no documented infection was mentioned by 2/3 of the consultants and over 1/3 of the pediatric residents as the parameter with the greatest impact in decreasing antimicrobial use. However, pediatricians also perceived that the same parameter, discontinuing empiric antimicrobials if there is no documented infection, was the most difficult to achieve. Once you've started, you want to just go on and continue. This article highlighted the fact that in a pediatric setting, diagnostic uncertainty plays an important role in starting and continuing empiric antimicrobials, which brings to fore two challenges that we pediatricians face. And these are improving our knowledge on local antibiograms and focusing on discontinuation of antimicrobials in the clear absence of infection. For the last part of this talk, research gaps and future plans. What are we missing? We still don't know the potential harms, sustainability, and cost of antimicrobial stewardship. Comparative effectiveness trials must be done to identify which is the most effective approach. Most of the clinical trials did randomization at the subject level, which opened the studies to contamination bias. And in this situation, cluster RCTs with randomization at the hospital level may be the most feasible way to provide high quality of evidence. And towards this end, large healthcare organizations like PIDSP or DOH, for that matter, could play a role by providing a venue for multiple sites, but with shared data. And this is exactly what the Department of Health and PIDSP, in a way, is trying to achieve. Last December 16, 2016, the Department of Health created a steering committee to oversee the implementation of AMS program in all hospitals in the Philippines. The steering committee is chaired by Dr. Berba, with members from various DOH units and with representatives from different medical societies. And of course, PIDSP and PPS are represented. Where are we now and where are we heading? So far, 16 hospitals have undergone training. This consisted of 15 public hospitals and 1 level 3 private hospitals. And up for training are the other level 3, level 2, and level 1 public and private hospitals. And when is the planned rollout? 2 months from now, that's April 27, the Department of Health plans to implement antimicrobial stewardship programs in selected level 3 pilot hospitals. And in August of this year, level 3 DOH retained and LGU hospitals will follow. For us, in level 3 private hospitals, towards the end of the year, we are expected to come up with our own AMS program in our respective hospitals. And for those in level 1 and level 2 private hospitals, you can relax this year, but next year, you should have your own AMS program. And how do we do it? We have to be guided by the Manual of Procedures for Implementing Antimicrobial Stewardship Programs in Hospitals. This document has been developed by the steering committee, and this contains the details of the 6 core elements of an AMS program: leadership, action, education, policies, guidelines, and pathways, surveillance, and performance evaluation. At this point, I would like to take a few minutes, just a few minutes, to share with you part of what is written under core element number 2, action. The AMS actions based on the DOH Manual of Procedures divide the antimicrobials into 3 groups: restricted antimicrobials, monitored antimicrobials, and all the other antimicrobials. Restricted antimicrobials are the 4th generation cephalosporins, aztreonam, all carbapenems, colistin, vancomycin, both the oral and IV preparations of linezolid, and all the antifungals. When you want to prescribe this, pre-authorization must be requested from the ID specialist and AMS clinician. Under monitored antimicrobials are the 3rd generation cephalosporins like ceftriaxone or cefotaxime, all fluoroquinolones, all aminoglycosides, and clindamycin. We can prescribe them all right, but after 2 to 3 days, then the AMS team will come in and do their prospective audit and feedback. For all other antimicrobials, we can still prescribe them, but point-of-care interventions like the escalation and IV to PO switch may be done by the AMS team whenever possible. And for all monitored and all the other antimicrobials, a 7th-day automatic stop order will be made. What about PIDS-P? What is PIDS-P doing as far as AMS program is concerned? PIDS-P has its own AMS program initiative. Last year, the research committee drafted a proposal entitled Evaluation of an Antimicrobial Stewardship Program in the Department of Pediatrics in selected private hospitals in the Philippines. Baseline data collection is about to start, with point prevalence survey to be conducted in collaboration with PSMID, utilizing the WHO Global Point Prevalence Survey instrument. Perception survey and situational assessment hopefully will be conducted in the next 4 to 6 months. We'll see. Intervention and evaluation will be done in collaboration with the Department of Health as well as PSMID. But whether it's PSMID, PIDS-P, other societies, or the Department of Health, all of these actions are aimed towards a single goal, that of persuading you, the prescribers, the frontliners, to follow the golden rules of antimicrobial prescribing. Microbiology should guide therapy whenever possible. Indications should be evidence-based. Narrowest spectrum must be ordered. Dosage must be appropriate to site and type of infection. Minimum duration of therapy must be given, and we have to ensure monotherapy in most cases. In summary, AMS improves patient outcomes and antimicrobial prescribing. The 2016 IDSA guideline recommends pre-authorization and prospective audit, syndrome-specific intervention, and rapid diagnostic testing. The recommended supplemental approaches are education, guidelines and clinical pathways, the escalation, dose optimization, and parenteral to oral switch. And finally, the Department of Health and PIDS-P and PSMID are one in promoting antimicrobial stewardship. But they cannot do it alone. They have to partner with us, the prescribers, the frontliners. After all, antimicrobial stewardship is a team game with the patient at the center, and it is our teamwork that will make the dream work. The bottom line, handle antibiotics with care. For if we use antibiotics when not needed, we may not have them when they are most needed. Thank you very much.
Thank you, Dr. Arciaga, for sharing with us your knowledge on antimicrobial stewardship and the procedure